So I have the great honor of introducing Roberto Cueva today. He's one of my most important mentors in my career. Dr. Cueva did his medical school at UCSF, his residency at UCSD, and then a Glasscock Fellowship, and has been at Kaiser Permanente in San Diego with one of the biggest skull-based practices in California. And we talk about that little voice in your head when you bump up against a difficult part of a case. And for me, that is often Dr. Cueva's voice. So I'm so happy you're here to give us a talk today. Thank you so much.
Thank you so much, Mia. I struggled a little bit with what to talk about, but I settled on ear canal atresia reconstruction, in part because it's something that not a lot of people do. And there's a lot of tips and tricks to make it a successful surgery. And I'll begin by actually recognizing two of the pioneers of this work. On our left is Bob Jarsdorfer, who he's passed away, both Antonio and Bob have passed away. But early in my journey on doing atresia surgery, he was very helpful. You kind of grab him at a meeting and talk about some of the struggles I was having in regards to getting good results. And he gave me a lot of good pointers and that really helped improve my results. And then, of course, our good friend and colleague, Antonio de la Cruz, who was there at the House Ear Clinic for decades, a consummate gentleman, and also, again, generous with tips and advice on how to improve results for my patients. A little bit of background on the ear canal atresia. It occurs in about 1 in 10,000 births, and the majority are unilateral. And there is a male to female predilection in a 3-to-2 ratio. And interestingly, the right ear is more common than the left ear, also in about a 3-to-2 ratio. For the longest time, we really just thought it was bad luck, but some recent evidence suggests a possible genetic etiology with some mutations on the long arm of chromosome 18 have been associated with a higher incidence of canal atresia. And so that's something that is probably going to become more, we're going to know more about it as time evolves. And then the role of surgery, bilateral versus unilateral, timing of surgery in that situation, and some historical perspective where probably 30, 40 years ago, if a child was born with a unilateral atresia, it was often recommended not to do anything. They had one good ear and would do fine without that. And this was driven by fear of potential complications, primarily related to facial nerve injury. And then as CT came on the scene, we began to be able to identify the course of the facial nerve. It became apparent that the facial nerve is usually in a normal location and surgery can be safely undertaken. And so there's no real limitation in regards to doing surgery in unilateral cases. Also, the evolution of bone-anchored hearing aids is another development that is an opportunity for rehabilitating hearing. It's an option. Some patients prefer it rather than going through a more significant operation, but others prefer the more natural appearance of an open ear canal and not having to have a device attached to the side of their heads. So what's the first step? You want to evaluate the patient. So as a neonate, you assess the degree of external auricular deformity. Are there any features that are syndromic? Think other syndromes like Goldenhar syndrome, hemifacial microsomia, things like that you want to be aware of because it can signal other medical issues that need attention, such as renal or metabolic disorders. At that age, we do want to assess hearing, both in the affected ear, but also in the contralateral ear, to make sure that the child can develop speech and language appropriately. And in unilateral atresia, the opposite ear is usually normal hearing, although not always. In the situation where you have questionable contralateral hearing, it's much more of a significant issue, and trying to determine whether that loss is sensory neural or conductive is important in regards to providing auditory stimulation early in infancy and childhood. And in bilateral atresia, again, you want to make sure that the hearing loss is conductive, because placing a Baha headband or bone conducting hearing aid allows that auditory stimulation for central nervous system development and sound stimulation for speech and language development. So again, we want to do, as the child develops into childhood, you can begin to do behavioral audiometry, and again, to monitor both the healthy ear, but also ensure that the affected ear is primarily conductive hearing loss. And again, amplification to the affected ear early is important for central nervous system pathway development in auditory processing. And even though pediatricians and the parents can sometimes be anxious to know what's going on in the ear, really don't recommend radiologic imaging until the child's around 5 years old, unless a canal hypoplasia and possible canal cholesteatoma is suspected. But to expose the child to the radiation in infancy, only to have to repeat it when the child is older and the anatomy has changed, is really useless. So you have to basically reassure the parents and then get the imaging at the appropriate time. So once the child gets to 5 years old, if they have a fairly normally formed auricle, you can start discussing potential options for hearing rehabilitation beyond the bone-anchored hearing aid or beyond bone conducting aids. And at that point, you get the CT scan, and that'll determine what's the status of the middle ear, the mastoid, the ossicular chain, the position of the facial nerve, the level of the middle fossa dura. Those are all important factors that go into determining whether the child's a good candidate for canal atresia reconstruction. Also, if the ear is malformed, consultation with our colleagues in plastic surgery for auricular reconstruction is undertaken at this age as well. And really don't do any MRI imaging unless either suspected cochlear nerve hypoplasia or atresia is suspected due to sensory neural component to hearing loss, or some other CNS pathology is suspected. And as I mentioned, what are we looking for on the CT scan? It's a degree of middle ear and mastoid aeration, the facial nerve position, both relative to the oval window and its course in the mastoid segment, the status of the ossicular chain, both the incus malleus complex and the oval window and stapes. It's more favorable if the incus and malleus are well formed. However, results with ossicular chain reconstruction at the time of canal atresia reconstruction, while not quite as good as when the ossicular chain is intact, are really quite acceptable. And again, we want to have oval window well formed and patent, and the round window patent as well. So the other position we talked about was position of the middle fossa dura, and that's noted on a coronal scan. So when we examine the ear to prepare for a canal atresia reconstruction, you want to have a pretty good cartilaginous structure to help maintain the meatal opening. Earlier in my career, I would have attempted to do canalplasty or canal reconstruction on patients with really nubbin auricles. They weren't interested in having auricular reconstruction, and without a fairly rigid cartilaginous framework, the meatus tends to constrict down, and those were struggled to get those cases to maintain an open meatus while the deeper canal remained patent. The position of the ear can be quite variable, both native, what they were born with, but also after reconstruction. and then the position of the temporomandibular joint relative to what is present for an auricle, because the created ear canal ends up being slightly superior and posterior to the TMJ, and you'll be able to counsel the patient and the parents where the ear is going to end up on the head following an atresia reconstruction. Timing of the operation is critical. There are some people doing very early auricular and canal reconstruction as early as 18 months. In my opinion, that's problematic, in part because the child is so small, it's almost inevitable that that will have to be revised because you can't create much of a canal size at that age. The structures of the middle ear and mastoid really don't reach adult size until probably 3.5 years old. And so if you're doing this kind of surgery at that young of an age, it's almost certain that the ear will have to be revised both from an external reconstruction, auricular reconstruction standpoint. I don't think the people doing this are putting adult-sized ears on an 18-month-old child, so it's something that I do not advocate for. So I recommend it be around the age of probably 5, 6 years old. And if the auricle needs to be reconstructed, I recommend that the ear canal be reconstructed after all external auricular reconstruction is completed. And that's a multi-stage process lasting typically 12 to 18 months. So parents need to be counseled about that time trajectory. The exceptions are whether in cases where there's canal hypoplasia and cholesteatoma can develop in the deep canal, or if the patient has no plans for auricular reconstruction. And I'll back up. Also, in my opinion, if they're going to have an auricular reconstruction, it needs to be done with rib cartilage. I now at this point do not reconstruct an ear canal in somebody who's had a med-pore auricular reconstruction. Every time I've done that, the med-pore ends up getting exposed, becoming a source of granulation, ends up having to be taken out because it gets infected. It's a nightmare. So when I'm counseling parents with a young child, I discuss that yes, it's more of a bit of a surgery and some more discomfort, but that the rib cartilage actually becomes living tissue and is resistant to being infected throughout the life of the patient. Whereas the med-pore, you can have a nice looking auricle, but if you're out gardening and something scrapes your ear and then that ear gets infected, that med-pore can never be completely free of infection. It has to be removed even from something like incidental trauma. So surgical risks related to canal reconstruction, again, we mentioned facial nerve injury as one of the factors that led to an aversion to doing unilateral cases many years ago. That is really not much of an issue anymore because we can tell where the facial nerve travels on the CT scan. Many people feel that they're more comfortable using facial nerve monitoring during every otologic surgery that they do. I use it on a very selective basis. And if I've seen the CT scan myself, which I do in all my cases, I'm confident that I know where the facial nerve is, and I've yet to have, knock on wood, a facial nerve injury during otologic surgery in a case that I chose not to monitor. But again, that's a personal choice. Every surgeon has to make that for themselves. Sensory hearing loss is also a real risk. You're doing a fair amount of drilling. Sometimes the atresia plate can be quite dense, and transmitted sound energy can reach the inner ear. It occurs, I would estimate it, in about 10% of cases. Most of the time it's relatively minor and affects mostly the high frequencies that don't affect speech and language comprehension, but it can be, in certain cases, a significant problem. All patients have to undergo general anesthetic. It's quite lengthy surgery compared to most otologic surgeries. The split thickness skin graft I harvest at the beginning of the case and get it from the inner aspect of the ipsilateral upper arm. Even in fairly, say in adults, this surgery can be done and is done in adults. Even in a fairly hairy male, the inner aspect of the upper arm typically has little to no hair. And that's an issue once the skin is in place in the canal and healed. A long number of years ago, probably 30, 40 years ago, most people, when they did the skin grafts, would harvest it from the buttock. And in males, I've seen patients who were operated, prior to that, this time, and they have a fair amount of hair growing in the ear canal, made keeping the ear canal clean quite problematic. So choose a part of the body that has little to no hair, even in adulthood. And that works well. The scar is typically a pale, flat scar, hidden against the body most of the time, and patients tolerate it quite well. The skin graft is really thin. Early in my journey in doing this surgery, I used a kind of a standardized disposable dermatome, but it had a skin thickness of 0.15 or 0.15 inches. And it would just be really hard to get the skin to lay flat. It wanted to curl up at 0.08. It's much more cooperative skin, but it does still want to curl up. There's some tips on how to get it into the canal and position it, but it ends up with a much better graft and better hearing quality because the skin on the drum is not so thick. The graft is about 5 centimeters wide and 7 centimeters long. Postauricular incision, if the patient's own native auricle is well formed, you just place it like you would any other postauricular incision. But if they've had a auricular reconstruction, there's usually a split thickness skin graft that is used to elevate the ear off of the head and create a sulcus. And I place the incision on the posterior edge of that so there's no new scar. The reconstructed ears are usually very, very stiff. However, they roll forward as a mono unit, and sometimes because of that position of the temporomandibular joint and where the ear canal ends up, it's common to need to excise an arc of skin along the upper aspect of the incision to reposition the ear upward on the head to align the meatus with the bony opening. In my practice, I use areolar temporalis fascia for tympanic membrane reconstruction and repair. I find it heals in a thinner fashion and it is more vibratory. In this case, I harvest a large piece, typically 2 to 2.5 by 2.5. In Jarsdorfer's papers, he really reports doing primarily a small graft, just big enough, a little bit bigger to make the tympanic membrane, and then lines the rest of the canal with the skin graft. I like to have overlap of the temporalis fascia up the posterior-superior corridor of the canal. That's where the air cells from the mastoid will often kind of be blending into the ear canal. I want to have an extra layer of tissue there to prevent the skin from beginning to dip into those little pockets and potentially forming cholesteatoma. Once the ear is turned forward and the fascia is harvested, the muscular periosteal incision is T-shaped with the upper one along the zygomatic root and the vertical along the mastoid, about 5 millimeters behind the palpable temporomandibular joint. And that will create an anterior musculocutaneous flap that is part of how the meatus is constructed. When you begin doing the bony drilling, your anterior margin is the temporomandibular joint periosteum, superiorly the zygomatic root, and then posteriorly the mastoid cortex. It's important not to get too far posterior. You want to stay out of the mastoid, and that's doing what is a modified anterior approach, which Antonio published about and was also described by our colleague Jarsdorfer. And then anteriorly along the zygomatic root, it's easy to go a little too far forward and find yourself anterior to the ossicular chain. So it's that kind of sweet spot along those three anatomic landmarks. Here's an example of a drilled canal. This is the tegmen along the roof of the ear canal. Here's the temporomandibular joint periosteum. And then here's the ossicular chain. This is an ear that's very favorably positioned in terms of the temporomandibular joint relative to the middle ear space. Sometimes the joint can end up kind of overshadowing the ossicular chain, and it's harder to get good contact of the created eardrum with the ossicular chain, or doing a reconstruction if the oval window is way off underneath the joint. It can be real problematic. So this is a very favorable orientation. And this little streak here is actually a chorda tympani, which is unusual to see in these cases. It's often positioned in such a way that you don't see it anatomically when you're in the midst of surgery. Here's another example where probably a little more bone here was removed than I would prefer. But again, a real direct shot at the middle ear. It's not always this pretty. And now the meatus is a real challenge. If you look at the incidence of meatal stenosis in those centers that do this work and report it, it's probably one of the more common complications. In Jarsdorfer and Brad Kesser's series, they will create a skin flap at the meatus that is anteriorly based and drop the skin flap down into the canal and sew it to this musculoperiosteal layer. I kind of approached it from a different orientation. And so this is a patient whose auricle was well formed. This is the tragus actually showing through the ear canal. So I do sew this forward, but I have a posteriorly based meatal flap that then I will rotate into the canal. And if you see these two holes at the bone, at the back edge of the created canal, those are for suture to hold the posterior flap in position. So the meatus has this kind of push me, pull you aspect, and it really prevents meatal stenosis. So it's quite low incidence is quite low in my series. And I think it's because of that construction of the meatus. So here's that large fascial graft. Here's the tympanic membrane area, and this covers over where those mastoid air cells kind of begin to connect into the ear canal. And then the skin graft is laid on top of this. So the skin grafts, if you look at Jarsdorfer's paper, uses one large skin graft and then with little darts medially. I found that's very awkward and clumsy to place. Took a lot of time, had a lot of excess often that I have to take the graft out, trim off excess, put it back in. So I've gone to using kind of wallpaper strips that I place the skin on strips of xyroform. And the reason I do that is to keep the skin from curling up. So when looking at the slide here, the epidermis is stuck to the xyroform and the dermis is facing us. So when the graft goes in, it's placed in initially with the xyroform, getting an initial positioning. The xyroform is then peeled off, which actually comes off pretty easy. And then the skin grafts can be tucked in position, pretty much just like wallpaper. And I think it's easier to get a kind of a custom coverage of the canal and the drum using the wallpaper strips compared to a big single sheet of skin. So the anterior graft, the one that goes into the anterior sulcus, I will make a little dart in the graft here, so that when it's positioned, the tympanic ring or anterior tympanic sulcus will be about here, and the part with the dart, those will lay on the tympanic membrane, and that dart allows it to lay flat without a bump there that you would normally get if you left it as a straight cut there. So here's that posterior based meatal flap. I don't make it circular, it's rectangular, and that in part is so that the tendency is for this to form a ring cicatrix. So as it heals, it rounds out. So if it's round to begin with, it'll tighten the round opening. If you start it as a rectangle, it'll end up round, but it won't tighten up the opening of the meatus. And then here's placement of those sutures into the holes in the bone through the flap to hold it posterior. Here's a piece of the skin graft with a xeroform in place anteriorly. So once the skin is positioned before the postauricular incision is closed, the two wicks, now these are cut at a bevel with the sharp part going in the anterior tympanic sulcus. They're expanded, and that holds that sulcus sharp. Bob Jarsdorfer preferred to use a circular disc of silicone, and that works okay if you're using an ossicular chain reconstruction with a flat-topped prosthesis. But if you have the ossicular chain, it's irregular in terms of its surface, rounded, and the disc, in my opinion, didn't conform to that well, and this beveled wick technique really gets things to seat properly on the ossicular chain and is conformal to the anatomy. Those are placed, and then the distal parts of the wallpaper strip skin grafts are folded down on top of the wicks. The posterior canal flap is sutured in place, and then the postauricular canal is closed, or the postauricular incision is closed. And once that's done, working through the meatus, you unfurl the wallpaper strip pieces of skin graft, and you suture the ends to the exposed skin incisions out at the meatus. So posteriorly, there'll be that skin flap down to the bone, but along the superior, anterior, and inferior aspect of the meatus is a cut edge of skin. The skin graft is sewn to that with 5-0 fast absorbing gut. That maintains the meatal opening, and then a second level of wicks is placed here to keep the meatus stented as well. Postoperative care is pretty straightforward. Obviously, dry ear precautions are used throughout this postoperative time. The parents or the patient is instructed to put otic suspension eardrops twice a day during the initial 3 weeks. And suspension is more effective than solution. So solution is an oil-based. Interestingly, the suspension is water-based, and it absorbs better into the wicks. So you see the patients at 3 weeks. The wicks placed at surgery are removed, and we check the position of the skin grafts and the take. New wicks are placed. So in the OR, I use Maricel-based wicks, which are more dense and really do a good job holding the skin in position and giving that gentle pressure to allow the blood supply to come from the underlying tissue, be it bone or soft tissue. In the office, I use the more porous Pope Otowicks. Again, the deeper ones are beveled, the more lateral ones are left as is. And then they go to using drops once a day. I see them another month after that, and that set of wicks that I placed in the first postoperative visit are removed and left out. I see them a month after that 7-week visit, do a thorough cleaning of the canal, and that's when we get our first postoperative hearing test. And to prepare for that visit and the cleaning, I have the parent or the patient use the eardrops for 7 days to help loosen the superficial slough of skin that occurs during the healing of the skin grafts. Long-term care is also very important in these cases. These cases the ears don't clean themselves like a normal ear canal. It doesn't have the migratory pattern of squamous epithelium that a native eardrum or ear canal has. So the skin will shed, but it just stays there. And if it's not periodically cleaned, it'll accumulate over time. And if it gets wet, will become infected, create a cycle of otitis externa, chronic laryngitis, and will often scar the canal closed and affect the long-term hearing result. So when the ear is cleaned, it can't be irrigated. It can't be scraped out with a cerumen loop. That's too traumatic for the grafted canal. So you have to do it very gently with a microscope. I use suction and an alligator forceps. And to prepare the ear for cleaning, I have patients put in 4 to 5 drops of baby oil 3 nights in a row. Have them put the drops in, lay their head on the bed, and sit there for 5-10 minutes to really allow the baby oil to percolate down into the canal. That does 2 things. The baby oil not only softens the shed skin, which can be quite firm, but it also insinuates itself between the skin and the underlying, the skin and the overlying shed skin, and it helps it slide out so that it's less traumatic. If you're peeling it off of stuff, peeling off a shed skin from the grafted canal, it will sometimes desquamate the skin and then lead to laryngitis. As far as allowing water into the ear, absolute dry ear precautions for a minimum of 3 months. After that, the ear can get incidentally wet in the shower and usually tolerates that quite well. I recommend they avoid swimming for 6 months, and that it really lets the canal mature and have the skin grafts be fairly robust. And I recommend they use rubbing alcohol and vinegar drops after swimming, or use a blow dryer to dry the ear, just again, because that skin that's shed will tend to keep moisture and be problematic. I've had some younger kids end up in swim team or water polo, and they sometimes will need more frequent cleaning during the sports season, just so that we avoid the otitis externa laryngitis problem. So this slide shows my experience through the end of 2020. I've done 206 atresia cases. Again, the 3-to-2 ratio for male to female and right to left ears has held up in my own series. And again, 70% have been unilateral, just as is published in terms of the statistics related to atresia. This data is through 2014. It's from a paper we published back in 2015. The average surgical time is 3 hours. As I mentioned earlier, it's a longer surgery than most otologic operations. And about 81% will achieve an airborne gap, residual airborne gap of less than or equal to 30 decibels. And if you look at pure tone average, 50% will be less than 30 dB. The mean postoperative intraoral difference is in pure tone average is about 28 decibels, and SRT is about 25 decibels when compared to the contralateral normal ear. And that is pretty much the average. There are some cases where you'll get just spectacular results, and others where it'll be less than satisfactory. The less than satisfactory ones will often be able to be revised in terms of either reconstruction of the ossicular chain, or sometimes the drum will lateralize and you can revise the medial aspect of the canal and get an improvement in their hearing. But it's usually enough hearing improvement that patients can localize sound and definitely report being happy with their surgical result. As I mentioned, sometimes we need to revise it to try and get that optimal hearing level, and about 25% of cases require that. And patients who don't want to undergo revision, or who even after revision may not have the best of hearing, they can successfully wear a hearing aid, a conventional hearing aid in the reconstructed canal. As mentioned earlier, complications. Out of that 206, there were 11 cases, or this would be 178 cases in this report. Out of 178, there are 11 cases of high frequency sensory neural loss. Usually the speech discrimination does remain unchanged. However, I probably have a handful, 4 or 5, where it was a significant impact on word recognition that really prevented the surgery from having a good benefit for the patient. As I mentioned before, no incidence of facial nerve injury, and the problem of delayed laryngitis occurs in about 10% of cases, and that can be minimized with good canal hygiene, being cognizant of how water impacts the canal, and staying on top of it. I mentioned earlier how helpful Bob Jarsdorfer and Antonio were in improving my own results in this surgery. So my early days, 1997 to 2002, I had a fairly high rate of TM lateralization. And that was in part due to my concern at the time of surgery, placing the wicks in the canal for packing. I thought they would stick and pull out my graft, so I would initially place ointment in the canal like I do for a regular tympanoplasty procedure, and then I would see them a couple of weeks later, suction the ointment out, and then put wicks at that time. And I talked to Bob Jarsdorfer at a meeting, pulled him aside and talked about my struggles, and he says, "Oh no, you can put the wicks in right away. They don't stick at all. And you can pull them out and it'll be fine." And so with his reassurance, that's exactly what I started doing, and it's worked well. So you can see in the second tranche of cases from 2003 to 2014, that drum lateralization has dropped to 16%. So by 2/3 a decrease in that complication. In those cases that require middle ear ossicular chain reconstruction, the prosthesis can displace in 9% of cases. If that happens, I will often, in the revision, go in and use a cartilage graft and then a Grace Medical HA light prosthesis with the adjustable platform, and I leave a little bit of the central titanium shaft exposed above the platform and impale it into the cartilage, and that will often stabilize the top of the prosthesis with the grafted drum. And finally, soft tissue meatal stenosis with the technique of with the anterior muscular periosteal and the posterior skin flap is 6%. Other reported incidence of that complication can be as high as 20% depending on the paper. So just want to start wrapping things up. So from 2000 to 2014, results improved in part from the guidance from our colleagues who had trod this ground before me. The change in the intraoperative ear canal packing was really critical in reducing that and bringing canal lateral or drum lateralization down and allowing for fewer revisions. Perfection in this surgery is extraordinarily difficult to achieve. It happens every once in a while in terms of hearing quality, but it's the exception rather than the rule. So you want to counsel the patients appropriately so they have an appropriate expectation of outcome. You want to under promise and over deliver rather than the other way around. But in practiced hands, you can achieve good to excellent results. You have to pick your cases well, and it's something that really takes a degree of dedication. It's one of those surgeries I think that can be more of a struggle than doing a small acoustic neuroma. And I often make that statement to the fellows when we're doing the case. The long-term care is really critical to maintaining canal patency and quality of hearing over the long haul. And I tell the patients and the parents that the patient will have to have their ear cleaned in an otolaryngologist's office every 6 months for the rest of their life. And if they balk at that, I'd say, well, if that's, you buy a car and you change the oil every 5,000 miles. You wouldn't buy a car and not do that because your car will stop running after a while. And so they in that example, they understand that the maintenance is critical to maintain function, just like any other thing that's important and needs maintenance. And I always discuss the option of bone-anchored hearing aid at the beginning of the journey and allow the patient or the parents to choose what they would prefer. I don't push them one way or the other. And I would say, like I said, some patients don't want to go through the more extensive surgery, and others prefer a more natural appearing ear rather than a device attached to their head. And thank you for your time and attention.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.